All right, good morning, everyone. I see adolescent medicine in the front. I'm Rakidia Torres. For those of you who don't know me, I'm faculty in the Division of Adolescent and Young Adult Medicine. I'm excited today to introduce you my co-fellow, Dr. Merrian Brooks. For those of you who knew us in fellowship, you may know that our former program director, Dr. Loretta Mateo, used to confuse us all the time, even though we look nothing alike. It's like when a parent calls all the names of their children before they get the right one. But to make things easier for her, we decided to become one person during fellowship and combine our name. And Loretta even graduated us under that name. Merrian's not only my colleague in adolescent medicine, but she's also my sister and other half. So here's a little something about my other half. Dr. Brooks is a pediatrician, adolescent medicine specialist, and global health expert. She was born in Virginia and raised all over the United States, moving with her father, who's in the military, and her mother and brother. She attended the University of Pittsburgh as an undergraduate with majors in neuroscience and the history and philosophy of science. She later received her Master of Science in Clinical Research during her fellowship here. She completed medical school at Ohio University Heritage College of Osteopathic Medicine and pediatric residency at Cooper Medical School of Rowan University in New Jersey. After completing adolescent medicine fellowship at CHP, she went on to complete a pediatric global health fellowship in Botswana through the Children's Hospital of Philadelphia. Currently, Dr. Brooks is an attending physician and assistant professor of pediatrics at the Children's Hospital of Philadelphia. She holds a joint affiliation with the CHOP Global Health Center and the Penn Center for Global Health. She is the director of pediatrics and research for the Botswana UPenn Partnership. Her research time is spent primarily in Botswana, where she focuses on improving health services and access to evidence-based behavioral interventions for youth. She is committed to improving health and well-being for adolescents in low and middle-income countries, as well as underserved youth in the United States. She is passionate about mental health, resilience, positive youth development, and well-being. Please give a warm welcome to Dr. Brooks, my other half, as she talks to us today about the global and pediatric adolescent health. Thank you, everyone.
I love coming back here to the original spot. Hail to Pitt for those who are Pittsburgh graduates. All right, so I'm going to talk to you today less about child, more about adolescent, global health, and what I think we can take home from our global health lessons and the ways in which we can be global health educators in various ways. So, all right, so when you look at this picture, what do you think we're talking about? I'm going to call in my second row adolescent colleagues. But what do you just think to yourself? What are we probably talking about? But what was that? Okay, good. What else? What's usually the first thing that comes to our minds? Yes, STIs, right? So, you know, nowadays, post-COVID, we have so much adolescent depression, it's often at the top of mind. But when we talk about the global health setting, we're usually thinking about STIs, HIV. So the other name for this talk is Global Adolescent Health Beyond the Genitals, right? And I'm going to talk to you about why I think we need to be focusing on the whole adolescent and thinking about the ways in which the whole adolescent is not seen in our global setting and how that applies to us. So adolescents and young adults, and depending on how you're defining them, between 11 and 24 or 25, 11 and 19, about 15% of the world's population. And 25% of them are in low and middle income countries. Many adolescent diseases and injuries are preventable or treatable. Behaviors start and are consolidated during the adolescent period and they have a major impact on the health of adolescents as they grow into adults. And adolescent health needs particular attention in humanitarian and fragile settings as we think about the barriers that our adolescents have when they're in stable, non-fragile settings and apply those to humanitarian settings. So one of the things that we talk about as an achievement in global health is the significant reduction in under 5 deaths. The under 5 deaths in the world have had a drastic fall, and that is wonderful news. Unfortunately, adolescents in the world have not had the same success. And this graph from the US actually shows what happens. So after the first day of life, the pediatric death rate drastically drops, and then it grows again during adolescence. And that's often due largely to external causes. In the world, when we think about where young people are dying, it is in the places that have the most adolescents in the world. So the Indian subcontinent, Africa, Southeast Asia have the largest volume of adolescents in the world. And the death rates of adolescents in those communities are also the highest. So when we think about adolescents, we have our community of adolescents in North America and our communities here. But if you are really interested in adolescent health, most of the adolescents are in the places where they're most vulnerable. So what are those causes of death? Road injury is number 1. Okay, this is from 2015. It's one of the, for the global population, one of the most recent we have. Self-harm is number 2. Interpersonal violence, diarrheal disease, and infections. Okay, so the top 3 have nothing to do with maternal health or sexual and reproductive health, right? They are related to, or even infectious diseases, which is the other thing that we think about when it comes to global adolescent health. The other thing that I want us to think about when we think about global health, and it is important for us to prioritize under ones especially, because under ones are still driving most pediatric mortality in the world. But as young people grow up, the causes of death shift. They shift to non-communicable diseases, injuries, unintentional and intentional injuries, and homicides. So here you can see non-communicable illnesses are in the yellow-green. The dark purple is unintentional injuries. That includes suicidal, or that includes road traffic accidents. Other intentional injuries are the slightly lighter color purple, and then homicides. So you see in the 10 to 14s and 15 to 19s, we see a lot of injury and self-injury and mental health related problems. And when it comes to so that was for boys. And so for girls, we see a similar thing. So we see some communicable diseases, but there's a significant reduction in communicable diseases as young people grow up. Then it's non-communicable diseases, which is a huge bulk, injuries, other unintentional and intentional injuries, and homicide. And when it comes to morbidity, right? So we don't just want our adolescents to survive, we want them to thrive. So 10 to 14 and 15 to 19, behavioral disorders, anxiety disorders, depressive disorders, iron deficiency anemia, making a comeback in there. But again, depression, anxiety, chronic illness that's associated with depression, anxiety, and mental illness, like migraine disorders, right? So we see that we have to think about the adolescents' mental health in the entire world. I remember when I first was thinking about global health, I thought, well, I'm going to go and think about HIV and TB and malaria, the things that we always think about. But what became very clear was that the neuropsychiatric disease was interwoven even into those things. And that in order to really think about what does it mean to be an adolescent advocate and clinician in the world, it means you have to center psychiatric well-being. So this is another way of looking at that information, except it talks about the ways in which these morbidity and mortality burdens are not equally distributed. So the second one, so the top is global, and then the second line is low income. So low income countries, when we talk about years of life lost and years of disability, low income countries are extremely much higher than the global average for adolescents. So we're not even talking about, not only are we talking about a difference in geography in terms of how the volume of adolescents that live in low and low middle income countries, but the burden of their disease is not equitably distributed. So we know that resource matters when it comes to adolescent health. So when we think about the world, we often think about, is it communicable diseases or is it non-communicable diseases? Are we shifting from communicable diseases to non-communicable diseases? And this shows, again, in the places with the most adolescents in the world, it is multi-burden. So when we think about adolescents, we always have to be thinking about them as whole people. Why does that matter? So adolescents, our world's adolescents, here in Botswana, where I am, in Southeast Asia, the world's adolescents all have important contributions to make in and of themselves. And we want them to be healthy in and of themselves, right? But there's a triple dividend that we talk about. So the social benefit of focusing on adolescent health is a triple dividend. That means that we get to think about adolescent health for the sake of the adolescent. We get to think about adolescent health for the sake of our adult population. And we get to think about adolescent health as the effects of healthfulness on epigenetics and the future of our society. So the epigenetic effects of their stress and distress on their bodies is going to affect the infants that they deliver even as adults. So I'm going to talk about the main things that get in the way of adolescent survival and thriving, and then I'm going to talk about what we can do. So accidents and injuries. So when we talk about multi-burden, we're talking about accidents and injuries as number one, particularly in young teens, so 10 to 14-year-olds. So fire burns, drownings, poisonings. So road traffic accidents, when you're a resident and you're trying to get through clinic and you're being told by your attending, you have to do all this anticipatory guidance, you have to do this, that, and ask these questions. It matters, right? Because we know that a huge burden of mortality in adolescence is these things that we talk to them about, right? So the types of road traffic accidents that we're talking about is they're the occupants of another vehicle, there are other passengers, usually with an adolescent driving, or they're a pedestrian. And in the world, the high income countries have a disparity in motor vehicle accidents. So deaths from motor vehicle crashes are highest in high income countries in the United States. But in high burden, high traffic countries, in low and middle income countries, we also see very high burdens. So why do we think that the United States has such a high rate of deaths from motor vehicle crashes? Why do we think it's so much higher than the rest of the high income countries? Fast cars, less walkable, right? So public health infrastructure, so public transportation infrastructure is one of the main drivers of our road traffic accidents and our deaths from road traffic accidents in the United States. And in Thailand, we see the same thing on a larger scale, right? So little to no public transport and also some cultural factors, right? So who's walking in the streets? So in a lot of parts of the world, they're not the drivers, but they're pedestrians versus cars, right? So young men in the world are often the victims of road traffic accidents. They're the ones who are walking to work. They're the ones who are walking at night. They're the ones that are drinking and walking. If you don't have a sidewalk, if you don't have covered sanitation, right? So all of these infrastructure things put young people at risk. So if you were interested in global health and you wanted to contribute, but you weren't sure how, helping think about infrastructure for transportation, sidewalks, and covering of open sewage and sanitation lines could save lives without you having to see a single patient, right? Firearms, another large cause of death in the world. Again, global health is the whole world. The United States, unfortunately, leads the charge in pediatric deaths and adolescent deaths in this substantially. Even in countries that don't have very strong gun laws or regulation of guns, the access is more limited by a whole host of factors. But this, again, is the way that the United States is leading in pediatric and adolescent death in the world, and what can we do from a global health-minded perspective to try to reduce this? We'll talk about that. So adolescent neuropsychiatric needs, as we've seen, are a huge part of what we need to be thinking about in all of these causes. Adolescent depression, anxiety, and other disorders are driving disability across the lifespan. And as you can see here, adolescence is where things are peaking. So depressive disorders are the first highest line. The next line is drug use disorders, and then the next line is anxiety, okay? So disability across the lifespan is peaking in adolescence and young adulthood, and it's related to mental disorders. And again, what we see is that these mental disorders are not equally distributed, and our disability across the lifespan. Eastern Europe is leading, again, mostly because of statistics, because they have good statistics, but they also have a lot of need, right? So Eastern Europe is the Appalachia of Europe, right? So that's the part of the European continent that we don't like to think about. We don't like to recognize when we talk about high income, but Eastern Europe has a lot of needs and a lot of poverty and a lot of recovery, cultural and post-war recovery that results in a lot of the disability that we see due to neuropsychiatric disease. And then we see Africa and Asia also with high rates as well. Really the whole world. So the whole world, but particularly some parts. So when we sometimes think of this myth of the happy, impoverished people who are, they're just so joyful. They're just so happy. I went to this village in Africa and they were just so happy, right? And they may be kind, they may be welcoming, and some of them may be genuinely happy. But we need to disabuse ourselves of this idea that they're not struggling from the same things that make every human being on the planet struggle. Okay. And how do we even know what's going on with neuropsychiatric disease in the world? So if you look at suicide data from the world, everything that's in red is no data for suicide. We're extrapolating information maybe from police records, for example. So it's no data. We don't even know what's going on in the area, for example, of suicide in all the parts of the world where most adolescents are. So we also have to recognize that one of the burdens that we're talking about is the burden of a lack of information. And it's important for us, again, as thinking about how we can bring global health into our lives, is to think about ways that we can help bridge the gap of data by helping to understand what the real numbers are for this. So, for example, in Botswana, where I am, which is at the bottom next to the orange country of South Africa in the south, what numbers do exist are extrapolated from police data. So it's not something that is regularly, thoughtfully curated. So what happens is the numbers that we get are strictly from cases that go to the police. So almost always murder-suicides. So we have an idea that all the suicide that happens in Botswana is murder-suicide, or 80% is murder-suicide. So they don't go into hospitals. They don't check the morgues. There are cultural reasons why people don't get postmortems or what do we call them? Autopsies. And so we don't know, right? And so we need to also extend, and this is the bidirectional part, we also need to extend our learning about how we develop these structures. So some people here in this room probably started something in Pittsburgh or in a place where you came from that didn't exist before. And taking that knowledge to places where they don't have the information can really help to bolster our knowledge in global health. We also have a huge problem with resources. So you all are living this every day. Every time a pediatrician walks into their clinic and has 5 behavioral health patients that are on a 6-month waiting list to see psychiatry, you are living this, right? We have a severe resource issue when it comes to global neuropsychiatric pediatric health, okay? We have very few professionals for every 1 million people in low-income countries, and it's also underserved in higher income countries. Less than 1% of most national budgets go to mental health in the world, especially in low-income countries. It's estimated that $16 trillion of economic growth is lost due to mental health conditions. And if your country is already struggling financially, the burden of this financial loss is immense. And only 0.4% of global health resources go to mental health programs. So despite us knowing for years that we have a huge burden of neuropsychiatric disease that also, by the way, affects communicable diseases that we care about, we still only provide less than 1% of the resources that are required. So some people ask, well, the reason we care about global health is I just don't want those diseases to come onto my shores, right? So in Ecuador, if somebody gets dengue or malaria and they come to the United States and they get bitten by a United States mosquito and suddenly there are mosquitoes in the population, that is tragic, right? But why is that person in Ecuador getting high viral load or parasitic load malaria? Because they might live in a house that it makes it easier for them to get bitten by mosquitoes. They might have no access to repellents. They might have to work at all hours, et cetera, et cetera, et cetera. So even if we only care about, the infectious disease, we know that all of that is trickling back to some societal issues. And those societal issues are also often affected by mental illness or mental distress, or causing mental distress in and of itself. So even the things that, we universally care about when it comes to global health, they come back to social determinants, they come back to mental health. So why are there so few resources that go to mental health despite the extreme burden? The top funders for global health, the United States used to be, I don't know what's going to happen now, but global funds the Global Fund to Fight AIDS, TB, and Malaria, the United Nations Population Fund, the International Development Association, the US and the UK governments bilaterally. So what is that funding primarily? Infectious diseases and sexual and reproductive health. So that's why I call this the genital agenda, right? So the money goes to prevent teen pregnancies and to prevent HIV and to prevent TB and malaria. And the argument always is, these are the things that we don't want to cross our shores, and we don't want an explosion in the population in places where people are poor. Okay? So it's a political agenda, whether we want it to be or not. So pediatricians are always preaching to the choir. Whenever I talk to pediatricians have a history of understanding that everything that we do is unfortunately political. And if we don't see that now, we're never going to see it, right? So everything we do is political. So the good thing about that is there's things that we can do. So in Botswana, where I am, it's a country of 2 million people. It's a middle-income country that gets most of its money from diamonds. And it's currently trying to strengthen its infrastructure, but it has one of the highest Gini indexes in the world, which is the disparity between rich and poor. So when you are poor, you are extremely poor. And when you're rich, you're extremely rich, right? And there is some middle ground there, but it's not as significant as it needs to be to sustain a thriving society. We have about 9 psychiatrists for those 2 million people, 0 child and adolescent psychiatrists, 1 adolescent medicine specialist, less than 20 clinical psychologists, and only 2 of them have a PhD. And most of the social workers there that are the largest cohort of potential mental health providers are not trained in therapy and do not feel comfortable doing it. Abortion is illegal in Botswana, except in cases of rape or incest. We have 10 pediatric subspecialists total in the whole country. That's all subspecialties. We are severely underfunded in the public health system, which means that we run out of antibiotics, we run out of nasal cannulas for children, we run out of birth control options, we run out of Miralax, okay? The most common presentation in the hospital for young women, so adolescents and young adults, is suicide attempt. And it has a high burden of about 12% of HIV in young women, okay? So in that setting, in the last 8 years, I have had to learn to adapt. When I first went to Botswana, I remember there was a case of a 2-year-old who was taken off of a ventilator. We only have a few. So COVID taught us about the resource that is the ventilator that we had taken for granted all over the world. But we already knew about this resource. So we had 4 ventilators, and there was a 2-year-old who was taken off the ventilator. And they were telling a story in Morning Report about how the family was upset that the patient had been taken off the ventilator and they were not aware of what was happening. And I came in, having been in Botswana for 1 month, and I said, how is that possible? You can't just take somebody off of a ventilator without their parents agreeing. What are we doing here? And they said, now, American, we have 4 ventilators, and the doctors decide who gets them. And the families just accept what we say. And in that moment, I've had many embarrassing moments as a person moving between cultures. But in that moment, I realized that though some of the things that I recognize as similar are there, the way that I think about them is different, because I think about them from the largest level of having potential access. And in the time that I've been there, I've learned to adapt to the restrictions, adapt to the lack, adapt to the societal, political structure that I find myself in, right? I spend 3 months a year at the Children's Hospital of Philadelphia. I go from literally everything, from GI specialists who only focus on motility, right, to a place with 1 pediatric GI person in the entire country. And in that experience, I have learned, and those who I work with have learned how to adapt to difficult scenarios, okay? So what have we learned that I think is relevant to everyone? There's this principle in many parts of the world, actually, but in Botswana, it's called mochelo. And mochelo is when you pool your money together so that one person can buy something big every couple of months. And it's a communal banking system. It says we may not have access to credit, we may make $50 a month, but we are going to try to have nice things at least once a year. So the principle that we all have learned over our time working in these severely restricted settings is mochelo. We have to pool our resources. Now is the time for everybody to care about global pediatric and adolescent health. Now is the time for everyone to care. Now is the time for us to be in community, for us to work together as much as we possibly can. Because working together is what we have learned over time in severely restricted environments. When you don't have access to all of the things, when you don't have access to all of the money, when you are politically restricted from certain types of medical care, what can you do? You can get together and find a solution. And we save lives in Botswana. We save lives every day. We lose more lives than we should, but we save lives every day. And the reason that we can is because of community. We can't afford in that community to not be advocates. And advocacy does not mean storming the castle. I mean, it can, right? If you need to storm the castle, right? But there are many elements to advocacy, and everyone should be one. Everyone should be one. It may mean education, right? Sharing expertise and evidence with the community and with policymakers, promoting public awareness, coalition building, communication, and lobbying, storming the castle, right? But there's so many things that you can do that are advocacy so that you can pool your energy to survive the restrictions and do your best for the patients that you love. So everybody here cares about kids and adolescents. You probably care about kids a little more than adolescents, some of y'all, but that's okay. You know, their pimples don't make you as cute. But we all are here for the shared goal of loving our patients, right? Seeing them the way they deserve to be seen, treating them with the best of what we have to offer, right? So in order to do that, we have to be advocates, because as we saw, road traffic accidents, you can do some in the office, but you got to advocate to prevent road traffic accidents. Allison Solba knows about these statistics when it comes to the United States and violence, right? So you cannot do everything in the office. You have to be advocates. So this is myself and the director of the Adolescent Sexual and Reproductive Health Program in Botswana. When we met 8 years ago, this program was about sexual and reproductive health. Now, this program is about holistic adolescent health. It was meeting with her, showing her data, and meeting with her bosses and presenting the information to the Ministry of Health that we were able to expand the way that we think about adolescents in the Ministry of Health. What we also have learned is that education has to be bidirectional, and it has to start with listening and learning. Sometimes people on one extreme will say, if all these people are dying, what we need to do is teach them, right? So let me come in with my degrees and teach, right? And oftentimes that messaging can be problematic because we don't even know what needs to be taught and what's a structural issue, et cetera. So the other extreme, though, is I'm just here to listen, right? I don't know anything about you or what you're doing. Just tell me what's going on. And by living in Botswana, I can tell you that the response to that, because people can be very frank, the response to that is, then why are you here? Okay? Then why are you here? You have something to offer, okay? You have something to offer communities that are different from your community. But you cannot be an advocate through education if you don't listen and learn first. It's like the patient who is overweight and you start loading in on how they just need to eat less, right? Or maybe they don't know about the food pyramid, right? When we know that that is often not the issue, right? There are many other issues that lead to that diagnosis, right? So instead of teaching and sharing first, we have to listen and learn. So listening and learning allows us to be the type of educators that is most useful. It also means that we're listening to all types of knowledge. So it's not just about book knowledge, it's about lived experience, it's about what the community has already figured out and working with them to get to the solutions that they are asking you for. It means that we value all types of knowledge. It means that we value everyone's voices, including our own. We also make sure that we collaborate, but we collaborate in the ways that people ask us to. So when I go to Botswana, this is a picture of me doing a community education event. Okay, this is the best picture I could get. The middle school asked us to come and talk to their students about mental health. So they asked us to do that. We understood what was it that their young people were dealing with. One of them was relationship problems, and we spoke to them at length about relationships. And you can see they seem to have a good time, okay? So the other thing I want you to think about when it comes to collaboration is that collaboration is on each and everyone's terms. That means that you may want them to be a co-investigator, but all they have the energy for is a couple of emails, right? Or you may want them to give your advice, to give advice on something, but they may want to be more involved. So they get to decide, if you're truly being collaborative, they get to decide how they're collaborating with you. So the main thing to know is that the way that societies become underdeveloped is by a lack of knowledge sharing. So it used to be that in the ancient times, people walked and traveled for miles and miles sharing knowledge. And then something happened in the course of history where knowledge sharing or not knowledge sharing became a weapon. So if we are looking to be advocates on a global stage and even in our local communities, sharing knowledge, not feeling like we're the only ones who know or the only ones who should know is an important part of that process. Coalition building is also about giving before we take. So I am a researcher. I have expertise in clinical care. The first thing I was asked for walking in as the only adolescent medicine person in the country was, can you take care of our patients? So this is me in Jamaica taking care of a little kid. But the main point is they want patient care first. So what does the community need from us? And what does the community asking us for? And how can we meet them with their desires before we come in with our agendas? Extraction can look like researching for your own career, which I'm always thinking about, hoarding information because you're the expert. And it may be our good vibes, right? Like we want to feel good about the work that we're doing in the world, right? So those good vibes might be the way that we're extracting, right? We're not giving the way people want us to. So even if extraction is for the public good, right? So we have a data problem in Botswana. I am solving that data problem in my own small way. But even though that's good for the community, I have to make sure that I'm also thinking about the priorities of the community that I'm working in so that we can meet in the middle and we can actually be a coalition. Low-cost innovations and culturally relevant adaptations. So in my work, what I do primarily is look at ways to share the love for mental health services. So this model that came out of Zimbabwe is called the Friendship Bench. We teach community health workers, lay people, folks that are volunteers, how to do problem-solving therapy. They sit on a bench or somewhere where they can find space, and they talk about their problems. And we have found significant success in having that model to expand the role for the community in mental health. So mental health is about services, but it's also about environment. It's about access to greenery. It's about access to activities, especially for adolescents. So thinking about ways to expand mental health and well-being beyond my role as somebody, as a part of the behavioral health team, that can be a low-cost adaptation that has the additional benefit of making the community feel more empowered. When we did this, our version of the Friendship Bench in Botswana with young adults, the young adults noticed that the experience of being a counselor was its own positive developmental experience for the adolescent. So thinking about ways to engage in low-cost innovations that are good for the patients and good for the communities are important. When I say culturally relevant adaptation, this is sort of an extreme example, but cultures exist right here in this room. There are people who grew up in rural places, people who grew up in cities, people who grew up in places with different dialects or versions of English, right? And all of that diversity could require a cultural adaptation. So understanding how culture is defined and using that to make sure that innovations of all types meet the community's needs. And get the word out, right? So what we have done with our version of problem-solving therapy and the friendship bench is we actually share this information with the community, right? So our advocacy is about saying, hey, community leaders who are not medical professionals or public health professionals, did you know that this is a problem in your community? And as a result of talking to communities, we have gotten them to take on their own mental health. They have started their own community listening groups in response to the data that we have presented to them. So getting the word out and being an advocate for communication means that we are getting information out to everyday systems, everyday medical professionals, so not just in the academic ivory tower, but the community people out there who need to understand the innovations and how they work. So getting the information out instead of comes from an outside hospital, eye roll, right? So we need to make sure that we are getting the word out to all members of the community and that we respect all members of the community. So what does this have to do with you? This is your corner of the world, okay? In this survey, it talks about the needs of Allegheny County residents. And it's based on income and household leadership, whether people are dropping out of school, whether people have been victims of violence. And the red areas are the areas of extreme need, and the light gray areas are areas of very low need. So in your county, how are you thinking about global health advocacy for your children and adolescents here? Advocacy is easy if you feel connected. And remember that you're connected to these kids as much as you're connected to our kids in Botswana, if for only reason you are on TikTok, right? TikTok travels, right? YouTube travels. So you are connected to the entire world, but you are certainly connected to these kids. Global health is public health and development oriented. And how do we think about public health in our own practices and our own communities? You may need to lobby, and you have some local heroes. So one is actually in our midst, Jan Madison. Okay, she was telling me a story last night. She's a pulmonary critical care doc, and she was telling me a story last night about how she didn't know what she was going to be able to do, how she was going to be academic and do all the academic things. But then she just started a pulmonary critical care program in Mon Valley, and she gets 100 new consults a month. That is advocacy, okay? You have Dr. Todd Wolin, okay? When his vaccine program got attacked, he created a national program. These are Pittsburgh people, okay? Advocacy is easy if you are yourself, bring yourself into your work, be unapologetic about who you are. Of course, everyone has to listen, but you got to be unapologetic and bring yourself into your work. Advocacy is easy when you expand the people that you know. So now is a time where we have to individually make it a point to get to know people who are different from us, because we accept and understand their needs when we get to know them as individuals. And advocacy is easy if you have courage. In Audre Lorde's Litany for Survival, she says, and when the sun rises, we are afraid. And when the sun sets, we are afraid. When our stomachs are full, we are afraid. When our stomachs are empty, we are afraid. When we are loved, we are afraid. When we are alone, we're afraid. And when we speak, we are afraid that our words will not be heard or welcomed. But when we are silent, we are still afraid. So it is better to speak. Have courage in every type of advocacy that you do for kids here and kids all over the world, and you will be a good advocate. And lastly, advocacy is about seeing patients the way they deserve to be seen, seeing them as holistic humans. It means that you provide care that's of highest quality, no matter who walks into the room. I myself always have to check myself when I have certain kinds of patients with certain kind of behaviors so that I can give them the best care. If that patient gets on my nerves, I stop myself and say, what can I do to make sure that that doesn't get in the way? Advocacy for the individual means listening and learning before you teach, right? You cannot lecture if you listen first. It means giving before you take. It means tell me what matters most to you right now, and then saying, let me tell you what I'm also concerned about. It means low-cost innovations. Those innovations will protect the individual patient and family's resources, the system's resources, and innovations that allow you to be nimble no matter what political or economic environment you find yourself in. And it means getting to know yourself and your culture and your context so that you can apply that knowledge to your interactions with others. Thank you so much.